I think we can go ahead and get started. Are you guys able to hear me okay? Yeah. Speak up a little bit more? Okay. So, I'm showing that it's now just past 11:30, so I think we'll get started. And as a way of introduction, I'm Blake Lusselroth. I'm one of the faculty in the Department of Medical Informatics and Clinical Epidemiology. And welcome again to the On Informatics series. And this particular one is our clinical grand rounds. And so just a couple of quick items, and then I'm going to introduce our speaker for today. First of all, for those of you that want to ask questions that are in our audience, I understand this is also streaming, but for those of you that are present today, don't forget that we love your feedback and your insights. We also want to capture them for posterity, so please don't forget that when you're asking a question, press the device in front of you and hold it while you're speaking, and that way it also projects and it gets recorded so that we have those questions for our distance audience. And the other thing I think is important to point out is that we have, this is actually also, you can collect CME credit for this. And so if you're inclined to collect CME credit for this, please contact Lynn Schwabe at schwabiel at OHSU.edu because I believe there's a very brief quiz, a brutal, punishing quiz that you just take afterwards, and then they will collect that information, and then you get assigned CME credit for it, which is lovely. So with that, I'm very excited to present our colleague today, Inho Kim, Dr. Kim. And as a way of background, Dr. Kim actually has a really interesting background. He started out in music. He was actually at Brown University, and I understand that he actually studied orchestra as well as trombone. So I suspect at some point that's going to wind its way into informatics. I'm not sure how just yet, but I trust it'll be exciting. And then after that, he went to the Medical College of Georgia to get his degree in medicine. And then following that, he actually started studying emergency medicine, and he completed his residency at New York Presbyterian in Manhattan, which is actually an academic affiliate of Columbia University. Since then, he's now joined us in the Clinical Informatics Fellowship here, and had actually completed a number of decision support projects at the VA just in the last semester. So today he's going to be joining us to talk a little bit of background information on clinical decision support systems, and then tying that into a real-world example of how he actually designed some decision support for with the intent to implement at the Portland VA. So with that, I welcome Inho Kim. Thank you so much for joining us.
Good? Yeah. So Dr. Mohan thought this would be a good dry run for me because I have to present on the order menu next week. So I would welcome any comments or improvements that I can have, especially on the order menu part. So just kind of what we're going to talk about today, a little bit about just a little brief introduction on clinical decision support and CPOE, because as many of the DMICE postdoc, postgrads here have probably heard a lot about CPOE and CDS. They don't want me to hear any more, but just a brief introduction, and then a little taxonomy on clinical decision support, and then the actual order menu at the VA. So a little bit of why we have clinical decision support. Part of that is one of the main impetus is the Institute of Medicine in 2000 came out with the fact that we're just making a lot of errors all the time. Like half our errors from adverse drug events are at the time of ordering. We're spending maybe $2 million per hospital per year because of these errors that we're making. But also, why does it relate to CDS? It relates to CDS because a lot of times those errors can be avoided if we had information at the elbows when we as clinicians are putting the orders in. And in the sense of like drug allergies, drug-drug interactions, and things like that. And also, we need to then use that information to make sure that we can continue to not make as many errors. Because I think it's impossible to not have no errors, but hopefully we can have less. And then so how do we do that? So part of the way we do that is we take that information and we kind of put it in front of the physician in the EHR. But there's a lot of information. Just even in 1976, with McDonald, they just found for them, before the internet, before all of that, there was already way too much information. There were already way too many papers, trials, and different things going on. And so we have to somehow take all of that information and put it at the elbow and make it useful, and not just have, hey, here's the million things that you can read about to figure out how to make sure that you don't screw up. So what basically is clinical decision support? So again, it's basically making sure that when the clinician is putting the order in or doing whatever they're doing in electronic health record, that they have their information, that tool at the elbow. And how to come up with what you use is kind of the Venn diagram you've maybe seen a lot, is taking the evidence, taking different constraints, like whether it's laws for like what drugs are FDA approved or not, and the patient-physician relationship and like what the physician thinks is going on. And when you put those together to find kind of the balance of all those, to find out what you want to use for your clinical decision support. The clinical decision support usually sits on top of the HR, and that's where I'm just going to talk briefly about CPOE. And that's basically the method or the way that a clinician can enter orders. That's, yeah. Some examples. It's just the way so that instead of having to type in from blank, like metoprolol 25 milligrams PO, that you can have metoprolol already in there because you selected it, and it has a list of whatever metoprolol comes in, 5, 10, 25 milligrams, instead of having to choose between milliliters, milligrams, grams, and everything. Just have everything kind of a little less cognitive overhead for the physician at time of ordering, so less chance of error. So, an advantage of CPO, again, the main advantage when we first started using electronic health records is first and foremost not having to worry about handwriting and transcription errors. There's pre-configured order sets for even speed if you're admitting a patient for chest pain. You don't have to go search for the CVC, the coags, and the troponin. If you're doing a pre-op order set, you don't have to worry about doing pain medications and IV orders. They're all just kind of pre-filled, and you can click. Yeah. Yeah. So that's, oh, so he just asked, like, who bundles these order sets and who, it depends on the hospital and the structure. So if there's a robust informatics program, usually the informatics group does. If there's not, for instance, at Columbia, where there wasn't a robust informatics program that's integrated with the hospital. They have a very good research group, but it's not very fully well integrated in the operations part. And so, for example, they wanted to have it so that for low-risk chest pain, you had 2 troponins and you had 2 EKGs within 30 minutes, and that was the order set, and there was CBC, et cetera. And that was done by the emergency department. There was just a physician who was part of the administration, who was part of QI, who, like, we're going to do that. Without kind of going about usability, going about, like, who is it going to affect, who's going to use it, is this the best way to do it, is this not the best way to do it? And so they just did it through their emergency department, and that's just how they did it. But if you're at a place with a more robust clinical informatics program, usually the informaticians would do that, with consultation with the cardiologists, with the emergency physicians, with nursing, with the lab techs to see, like, is this the best lab? Is this the right way to put that in, and different things like that. Does that make sense? Yeah. Yeah. So some literature support for clinical decision support. So there's no, like, 100% that, at least in evidence-based medicine, that clinical decision support is the best and be-all, end-all. There's been studies before that were systematic reviews that showed, yes, it's very good. There's been a couple that were like, it works, it kind of doesn't work. I just wanted to show you a more recent one from 2014 by, I don't know how to pronounce the name, Moja et al. And they did a systematic review up until I think 2013 or 2012. And from those, they had about 3,000 studies. But from those 3,000, they pared it down to 16 of them to check for mortality to see if clinical decision support actually, for better or for worse, affected mortality. And they found there was no change. Adding a clinical decision support system to an EHR or comparing a EHR with clinical decision support to one without clinical decision support, there was no change in mortality, like benefit. And then when they did a morbidity outcome with 9 other studies, they found that there was maybe some association, but it wasn't a clear-cut, like definite, yes, it's much better having clinical decision support, at least evidence-based medicine was. So when designing clinical decision support, what are different ways to go about doing it? There are many different ways. Like Orschluff, I can't pronounce the name, has like the 5 rights, the right person, the right information. There's many different ways, but one of the ways that I like to think about is Bates. It came out from Brigham's. They studied a bunch of clinical support to figure out, what do people really need or want when it comes to clinical support. And one of the first things that really pops up is speed is everything for clinicians. Like, you're already working a long day. If you're a surgeon, you're there at 5 o'clock. You're rounding on your patients, and you're going to the OR. You don't have time. So speed is everything. Also, it's to, as said before, clinical support, it's making sure that the information is at the elbow. It's there. They don't have to go hunt for it. You don't have to go to somewhere else, wherever that may be, website or wherever, to find that information so that you can have that information at point of care. To understand the workflow so that it's not, again, in some weird place where the physician has to go outside of their way to find it, which all kind of sometimes comes down to speed and, of course, usability. Other things to think about is that it can't be too complicated, as with like the 7th point, and like that's why kind of Google is so successful. It's like Dr. Lesseroff pointed out to me earlier. Instead of having it all complex and having out there in the front, Google is very powerful. It can do a lot of stuff, and it can search for anything and everything if you know how to search for it and use the terms. But the interface is simple, so that you don't get put off by that. And so to have simplicity, it's easier to modify than to cancel, because I don't know if for those of us who've been in EHRs, if you have to cancel, sometimes you have to go to the very beginning. You have to then click the order button, which pulls the order up, then find the medication, then go to the medication, and then put in the dose, and then press OK. Whereas if you can just modify that at that point, where you can just change the PO to IV at that point because you clicked the wrong thing on the second step, it's much quicker, it's much easier, it's better. Other things is to make sure that you're studying what you've implemented. Because just because you've implemented it and you've talked to all the stakeholders, got all the buy-in, did the usability, and you think that it's going to work and you've worked through the workflows, doesn't mean that it will work. So to make sure that if you've implemented a clinical decision support, that you study it to make sure to see what its impact is, see if it's any good, see if it's actually improving care and decreasing errors, which is kind of, again, going back to what all this was about, of having clinical decision support, decreasing errors. 8 is going back to kind of simplicity, making sure that you're not having too much of information that you don't need at the time that your physician or whoever is putting in the orders or putting in the notes, etc. Just some other things. The kind of main point of this slide is that it's not just the technology. Because sometimes the hospital, the department, the section, the group, the clinic will come and say, hey, like, make us a tool or a widget or something to fix too many patients coming in at once. And sometimes it is a tool or widget that will help, and sometimes it's not. Sometimes it's a workflow issue. Sometimes it's a personnel issue. Sometimes it's an education issue. So it's not that technology is the be-all, cure-all. So there are different taxonomies of CDS. This is just one of the random ones that I picked that I liked. It was done by Adam Wright, Fittig, John Ash. basically, these are the ones that they came up with. How they came up with this, they went to multiple sites. I think it was like, I don't remember the exact number. I think it's about 7 large institutions. Some were Epic, some were Cerner. I think 1 or 2 were homegrown. And they tried to survey the sites and see what they had when it came to clinical decision support. And they took all the different kinds of clinical support they had and put them in. And then from looking at those, made these 5 categories. So just to tell you a little about each category. So medication dosing support. That can range from a lot of different things, and one of those things can be just having default dosing, so that you don't have to memorize what ibuprofen is, or if it's been a long time since you've given albuterol, to remember exactly what that dosing is and whether it's micrograms or milligrams. So it's all there. So again, less cognitive overhead for the physician, less chance for errors, hopefully better patient safety. Order facilitators. This is something like if you're in your primary care clinic and you order a stat, and you know that you have to order liver enzyme. But if you're seeing 20, 30 patients a day, it's very easy to forget that. So the order facilitator, an example is when you order a statin, it automatically allows you to order a liver function test if you wish. And hopefully so that you can follow up, hopefully so that if they do have a bump in liver function enzymes, like you can catch it. Point of care alerts and reminders. These can be anything from reminders to check the hemoglobin A1C every 6 months, to tell you that, like as this example is saying, that you don't need to maybe order the metoprolol because the patient is already on atenolol, because they're both beta blockers. Relevant information display. This can range from anything from telling you the cost of the drug or the lab test. For example, if there's one case where an emergency department started labeling the point-of-care CBC tests because those were $3, whereas I think at that institution the CBC lab draw, the regular lab draw that wasn't a point-of-care, was I think around the lines of 5 cents. And so it costs so much more. So the residents were using the point-of-care test because they wanted to see who could see the most patients in a day. So when the point-of-care test came out, they just used it like crazy. And so the bill that the emergency department got for using that, which is obviously much higher than they're used to. And so they said, like, please use it sparingly only when needed for emergency cases where you know that you need that CBC within 10 minutes for the fast GI bleeder or whoever that may be. Expert systems. This, at least in my mind, an example is like the PCA, order menu kind of algorithm at the VA, where at the VA in the summer they found out they were having trouble where interns, surgical interns, were incorrectly inputting PCA orders, usually way too high.
Perhaps you could, for the non-clinicians, maybe describe or clarify the acronym PCA.
Oh, sorry. I don't know what the acronym is. Is it patient-controlled analgesia? Is that what it is? Yeah. So, for basically a lot of post-op patients, especially ortho and every post-op, we've, at least from what I remember from medical school, better pain control that a patient has, the quicker they can go home. And so to kind of help with that, we have PCAs, patient-controlled analgesia. But unfortunately, with interns ordering PCAs, we found out that they were giving much too high of a dose. And so to kind of combat that or kind of improve that or make that better, at the VA, they had an expert system which would help the non-expert, the intern, to classify and place the post-op patient into the correct PCA dosing area, so they wouldn't overdose patients. Workflow support. This is something as simple as having an automatic termination of an antibiotic order. So if it's 5 days of, which is typical for pneumonia, for azithromycin, it's an antibiotic that you usually take if you have pneumonia. And so it would stop after 5 days instead of having to, one, one problem is, like, one, if I have to rewrite it every morning as I come in to write the azithromycin, or two, if I wrote the azithromycin and the patient's staying for more than 5 days, if he starts getting on the 6th day, I don't want that either. And so to have an automatic stop order on drugs like azithromycin for pneumonia. So then we come to another part of the talk of, like, why I'm talking about all this. So kind of the longest way this came about was that in 2014, the FDA started, I don't fully understand it. It's like a pre-warning warning. In 2014, December, they said there's maybe an increased risk of thromboembolic events. Those are like blood clots, heart attacks, strokes, which are kind of all goes along with blood clots, and deep vein thromboses if people are taking testosterone. Then finally in March into April of 2015, they finally came out with a warning and stated that that warning is true, and that all testosterone products must be labeled stating that there's an increased risk for cardiovascular events, strokes, and clots. So the VA noted this and decided we need to do something about it. So at the same time, they wanted to find out, I think they did a little kind of query and found out that many veterans were receiving testosterone even though they shouldn't be, for various reasons. Many veterans were wanting testosterone because they were just feeling weak, because they were getting older, because they had decreased sex drive, for various reasons. But the reason why this is important, we'll get to later, is that the risk-benefit ratio for testosterone isn't very good. It's very slim. So testosterone is only beneficial for a very small population, at least according to the FDA and Endocrinology Association. And also they found out that even though testosterone was being prescribed to the incorrect set of patients at the VA, they were also not getting the appropriate follow-up. They were not getting the appropriate lab testing, and they were not getting the appropriate follow-up as in to look for signs for bad side effects for testosterone. And finally, they were also finding that there was some inappropriate drug delivery because some were getting gels when they shouldn't be getting gels, and some were getting patches when they shouldn't be getting patches, etc. So the VA was like, well, one, we have this warning that we need to tell all the physicians and clinicians and providers at the VA to make sure they tell all their patients. 2, incorrect patients are getting testosterone. 3, they're not getting the follow-up. And 4, they're just not even getting the right kind of testosterone. And so they charged the Informatics group and the order menu group at the VA to somehow improve the appropriate use of testosterone at the VA. So in starting that, it was to find out who do we need to talk to accomplish that. One was, as you can see here, the lab, the endocrinology department, other primary care physicians, patients, pharmacy, were the main people that we talked to try to figure out how to do this. So in challenges of CDS, these are the challenges, and I'm going to go through them, and you'll see why they're important. So one is the information isn't complete ever. So when it comes to information in medical school and everything, we moved away from textbooks, and then we moved to evidence-based medicine primary literature. But there's so much information out there. If there was so much information out there in 1976, there's definitely much, much more information out there now, and there's too much. And it's not complete, even up to date. So an example is if I go up to date I can't go for orthopedic stuff because they just don't have very much orthopedic stuff. But if I need background information, I'll go up to date. But when I want to actually treat a patient, and I don't know as much as I would like to about it, I'll go to e-medicine. So even places that are known to be more comprehensive, more complete, and more quote-unquote up-to-date are still behind at times because they're still having to find all the literature and go through the literature. It's ambiguous, and this relates to the testosterone in the sense that the FDA came out with this warning, but part of it is from just papers, but they're all very inconclusive. They say that there might be an increase in cardiovascular events, there might be an increase in stroke, and there might be an increase in having deep vein thromboses, but it's not wholly concrete. It's not like, yes, like 100%, everyone will have a horrible increase and it'll be really bad, and the percentage is 20%. There is no number. And so it's very incomplete. And so if you go to a place like National Guideline Clearinghouse, they kind of take all these guidelines together, and the guideline that the endocrinology department used and I used, and I think partly what the FDA used, was a guideline from 2010 done by the Endocrinology Association of America. And basically, that guideline stated that there is no kind of solid number that you can follow to say, yes, if you have low testosterone and you get testosterone and your testosterone level is this level, it's okay for you to take it. Or if you have one event, it's not okay. Or if you have two events, it's not okay. Or it's okay if you have almost an event. And so they're very ambiguous guidelines. So other challenges, data is very dispersed. So if you can imagine, like, just Manhattan, like the number of hospitals, there's, I think, it's missing St. Luke's Roosevelt near 59th and Columbus, if you are familiar with Manhattan, and it's missing a couple others. But this is just some of the hospitals in New York, and they all have different EHRs, and they all do not communicate with each other. Even though they're supposed to, they still do not yet, because there was like a New York Health Exchange, but it still doesn't really work because no one uses it. So data is dispersed for your patients and to find out what allergies they have, what medications they have, and what medical problems they have. And finally, again, there's just too much information. As some people know from going to medical school, like, it's drinking out of a fire hose. And to try to compile all that information and to make a clinical report is very difficult. So what happened? So basically, again, the VA decided, yes, we need to have this warning. We need to follow the guidelines, and we need to have better follow-up and have better use of the testosterone at the VA. So just to give you details of what that entailed, so in talking to the endocrinology department and pharmacy in the lab, that entailed making sure that they had 2 testosterone levels that were differed by 24 hours. So if you got a testosterone level on Monday, then you got another testosterone level. Earliest was Tuesday. They had to be at least 24 hours apart. If those 2 were low, there's another further algorithm to differentiate with primary and secondary hypogonadism, but that wasn't as important for prescribing. Well, it is important, but at least not for this talk. And so if you found out that they had true low testosterone from hypogonadism, as in because they were not producing enough testosterone, you could be on the way to maybe getting testosterone. The second part, they had to make sure that there was good follow-up, so that they had, at 6 months to 3 months, there was a repeat CBC and a PSA. PSA is a prostate-specific antigen. The reason that needed to be followed up was if you're on testosterone, it can increase your risk of cancer. And again, this is more ambiguity with guidelines. They know that it's associated. As far as I know, it's associated, but there's not direct evidence that, yes, if you have an elevation in your PSA from taking testosterone, you are going to get cancer. And so with the ambiguity, it's hard, but it needs to be followed up at least and tracked. And the CBC needs to be tracked to make sure that the hematocrit wasn't above 54%, because it can increase your red blood cells. And then finally, they need to be tracked, and this is the most ambiguous, to see what are the benefits of getting testosterone. Because of the FDA warning, the VA knew that there is some risk, whether that number is 5, 1, or 0.5% increase of having clots, of strokes, and cardiovascular events. We don't know how much, and they had the benefit of how much better the patient felt on testosterone. So at 3 months and 6 months, the clinician is supposed to figure out, yes, my patient is feeling, I don't know, it's like there's no guideline of he's having sex 5 more times a month, and so it's okay because even though now his stroke risk is increased to 5%. But if he's only having sex 3 times a month, it's not okay. And so there's no concrete way to determine that. And so more ambiguity. These are just the goals I just talked about. And so what we did, and I kind of classified it into the right taxonomy. We said medication dosing support, order facilitators, relevant information display, and some expert systems. So medication dosing support for the testosterone menu. This is the basic testosterone menu. What are your, I don't think you can read it, but any first thoughts on seeing it? Especially with what I've talked about. Yeah, there's a lot of words. Yeah. So the kind of issue with that is, from the VA/FDA standpoint, like we had to include the warnings that the VA wanted about the increased cardiovascular risk. So that's a lot on the right. That's all the risks that they wanted us to include, like the right top corner. So yes, it is a lot of words. So it's like really breaking like a lot of the 10 Commandments. It's not simple. It's a lot of words. It's complex. It's not maybe information that you need. But again, to go back to the medication dosing.
Oh, another thought.
Yeah.
It looks like you were struggling with, it's hard to see where the entrance and exit is of this order pathway.
Yes. There isn't a clear, so part of what we were thinking when we were doing that was just that hopefully they would start at the left top corner and then hopefully go to the right bottom. But there isn't a clear, yes, start here and end here. For medication dosing support is just the warning that they shouldn't exceed 400 milligrams of testosterone for every month or every 28 days. Second, for an order facilitator, when they order testosterone, when the physician or provider orders testosterone, it automatically generates a way for them to order a PSA and a CBC in 12 weeks to make sure that there's going to be a lab. They might not follow it up, the physician or the provider, but at least there'll be a lab for someone to see, hopefully. And then relevant information display. And this is the too many words. Right on the right is what was on the right top corner, which is all the testosterone warnings and cautions about the increased cardiovascular events, the increased stroke, increased thrombotic events. And then the bottom is the contraindications. They wanted to make sure that we had what, if you had any of these other things, you could not be placed on testosterone. Things like prostate cancer or and again, this is more ambiguity, uncontrolled heart failure. I'm not sure, like, at what point you become uncontrolled heart failure. Does that mean that you had an admission twice a month, or does that mean you had admission 3 times a month for your heart failure? It's hard to know. On the left is the only thing that I thought was very useful. I don't know if everyone agrees, but it was to kind of educate at the same time as the provider was putting in the orders for trying to diagnose hypogonadism, which is low testosterone, which is to tell them that they need to be 2 testosterone levels, 24 hours apart to diagnose hypogonadism. Some expert systems and relevant information display. When you're testing for testosterone, there's total testosterone and free testosterone. And if you're not diabetic and you're not obese, you can be tested for total testosterone, whereas if you're diabetic and you're obese, you need to be tested for free testosterone. And that was more of like the kind of expert systems, kind of relevant information display, as opposed to just having the total testosterone, just the free, so that the provider knows which one to pick for their patient. So depending on it is just going live, it's just on live, depending on the data collected, because we need to study the implementation to see whether it actually did improve. Like, does it make it worse? Are more people now getting testosterone who really don't need testosterone because we put it all on one page? Did it improve the appropriate use of testosterone for VA patients? So hopefully we'll be able to study that with data we'll collect over the next months. And again, and for other revisions. And it's the other problems with when should we revise this? Because it's so ambiguous, because there's so much information. Even if you look at the idea of it going live this fall, kind of the impetus started in 2014 December. So it's already like a year later, and that it's being implemented. So on some level, you could say the information is a year old. And so then how often and how soon should we be revising this for information that's always going to be incomplete and almost always ambiguous. I don't know, does anyone have any comments on the ambiguity question?
Think about is, yeah, I don't have a button, sorry, is there's a lot of ambiguity, like you said, but in my limited experience, it will almost be helpful to like have citations in there to say like, this is where this ambiguity comes from. Like, these are contraindications, but they're kind of soft contraindications. Or, you know, I mean, does that make sense?
Yeah.
Because otherwise, you're just taking the computer's word for it.
Yeah.
And there's a lot of decision making that's being taken away from the clinician.
Yeah. No, and then, oh, basically your comment was that you like what you're seeing, except that you wish that there was a citation for the contraindications, for the guidelines, and for the recommendations or reasons. Yeah. And so, no, I like the citations because I've seen other order menus with citations, but the problem was that there were already too many words that, like, I kind of...
Yeah, could you have some sort of, like, read more link off of this page?
Yeah, maybe. It was, at least at that point, it was just, there's so many words that, like, if I could not have more words, it was, yeah. Yeah, but I definitely...
There's also a lot of empty white space in that menu.
I think that's, I don't know, is that a VA thing? Yeah.
Yeah, to be fair, and I'd like to actually hear, maybe Inho will give a little bit more an explanation or insight into some of the decisions he made, because I have a little, I know enough to know that the requirements he was furnished, or at least the content that was furnished to him by the Department of Endocrinology, looked quite a bit different than this. So he had to go through a lot of steps to translate pages of material into something that was consumer ready at the point of care. And so aside from the fact that he was getting content that had to be recompiled in a usable way for the computer, he also, I personally, working at the VA, I like the CPR system, and I think it's very good. But nevertheless, I also concede that the menus themselves impose a lot of design constraints. For example, you can't color your font. You can't change the font size. You can't change the color of the menus. There's not a lot of branching decision logic. So he also had to contend with some of that. So what you're looking at are, it looks like a number of compromises that Inho had to make between what the stakeholders wanted, what would make sense as an informatician, and what design constraints were imposed by the health record system. I don't know, maybe you want to comment about that, because I know a lot went through your head going from what you received from stakeholders to what we see on screen.
I guess some things, there was definitely a lot more they wanted in the menu and put in the menu, because it was about 4 pages of single-spaced reasoning and logic that they thought was very important. And so part of it was, how do I get that in there at the same time as not like overburdening? And it's still kind of a lot of words. Yeah. As for the white space, I think it's just like, it's like a inline, command line interface. So we have to type in each line of like printf. It's like, oh yeah, this line, and then print this line, and then this line. So it's just the way kind of it is. You can't graphically make it that much more pretty. At least not in CPRS. I think in other things it can be done, and can be done really well. And yeah, but yeah. Any other comments, questions?
You talked about expert system. So based on what you said, it doesn't sound like expert system. It's expert support system, probably. And the question was,
yeah.
Do you know any other expert systems in
so no, it's not an
at
expert
OHSU that are implemented already?
So it's not an expert system in the. I think maybe you're thinking about like an expert system, as in like it takes actual patient data and then takes the evidence and then gives you like a diagnosis or a drug. Is that what you're thinking
like
of?
Yeah. Expert
No.
system is
No. So yeah.
artificial
So he's
intelligence.
not. Yeah, he's not talking about. Wright's not talking about that kind of expert system. He just means an expert system is as it's taken some of the thinking away from you, so you don't have to think about how to do a transfusion. Like, so you don't have to then think that oh, I have a GI bleeder whose hemoglobin is 7, but he's hemologically stable, but he's a little tacky. So you don't have to like go through all those things so that the EHR will tell you he's tacky and hypotensive and hemoglobin is 7.5. In our system, he needs to be transfused, and it just tells you that. I think that's the more kind of expert system. It's not like it's not as complex as what you're thinking about. It's more of a taxonomy expert system that he's using, vocabulary, not like big world expert system AI, like taking real-time data and like giving you these great answers. One day, I hope to have that, but nobody has that right now.
If I might say, it's an interesting comment. I think where Wright's coming from, Ash and Wright and a number of others, and frankly, a camp that I also tend to occupy is we tend to use a larger working definition for expert systems. When you were talking about, I think you're getting to the point that some expert systems are what we used to call the Oracle systems. You put information into a computer, and in return, you get some sort of answer, as though all of the thinking has been done essentially behind the curtain. And while Oracle systems are still out there, and by the way, there are flavors of that. I know that one of them, probably the most highly celebrated of sort of those Oracle systems, and that generation of sort of decision support was what was developed at the Intermountain Healthcare System and their health system. So essentially, every time you see a patient in the ER in Salt Lake, and you start inputting information into that health record system, it was generating content that would help sort of drive the decision making. Oh, this patient appears to be infarcting. You need to move them to a cardiac care step-down unit. So it was taking a lot of those calculation steps off of your, out of your responsibility and out of your hands, and placing it sort of behind the curtain. The interesting thing, though, is that there also is some backlash to Oracle systems, and whether or not, by hiding or suppressing some of that content, whether or not actually you're getting buy-in from your clinicians. And by and large, that's actually something we still struggle with today, is the more you essentially suppress or conceal a lot of that expert thinking, sometimes you'll actually see a rather visceral response to your end users. Oftentimes, clinicians don't like to think that the computer can outthink them. I myself, being a clinician, I'm a little bit unsettled by that prospect that maybe there's a Watson out there that can do a better job than what I've trained my whole life to do. Now, admittedly, that's somewhat emotional, but so with that in mind, a lot of what we do, say at the VA, and a lot of expert systems, rather than actually running or crunching the data behind the scenes, we conceptualize expert systems as how do you represent data or in a schema that actually is emblematic of the way an expert thinks. Novices, they tend to have information just sort of scattered or distributed, whereas experts tend to consolidate things into very sophisticated schemas. And so arguably, if you think of expert systems in a larger framework, much as the way Adam Wright is doing, you can argue that some of what Inho has done here is actually try to model expert thinking. How does an expert endocrinologist approach the problem of potential hypogonadism, and is there a stepwise approach? He's tried to do that here within, again, admittedly, the decidedly strong constraints of this particular clinical environment.
You have a date published on this page? Just
Oh.
because I'm thinking...
It's in the, is it on top or is it in the background? On the blue, yeah. It's August of 2015. Yeah.
I was just making sure, because
Yeah.
I don't know, you brought up the whole thing at the beginning
Yeah.
of like up-to-date in e-medicine, like
Yeah.
really not up-to-date.
Yeah.
I know if I wasn't seeing the system, I'd be like,
You'd want to know.
when's
Yeah.
the last time someone looked at this?
So, anything else? I have a urology question. So it's one that we didn't get to ask when we were doing this was, what is there a PSA cutoff at the 6 months or 3 months that you like?
You covered that issue well. I don't think there is.
A number, like there's no definite number that, okay.
But you're getting, I think you picked a great problem, a difficult one to approach with your project. You use it to make your life easier by something more cut and dry because of the many issues you brought up in your lecture. But no, there isn't. And in addition to some other diagnostic issues, I think your audience here, as you said, was primarily primary care and endocrine, who are more likely than not to know some of the competing diagnoses,
Sure.
like pituitary female
Sure.
cause. Also, some of the alerts that would fire back, I think most people would intuitively know without having to describe it about the polycythemia.
Mm-hmm.
So,
Yeah.
but yeah, so some of the urologic implications here also
yeah, that's basically talk.
For another scintillating on informatics lecture from Dr. Kim, and I definitely encourage anybody that has further questions to please join him down front. And again, I appreciate everybody's attendance today, and look forward to seeing you next time. And don't forget, if you're interested in claiming the CME credit, that will be available. Please contact Lynn Schwab. Thank you so much.